Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers, producer of Public Health on Call. Today, all about the new products intended to reduce severe RSV infections in babies and young children by 60% or more. Professor Ruth Karron of the Johns Hopkins Bloomberg School of Public Health speaks to Dr. Josh Sharfstein about what these products are and why some people are having trouble finding them for their children. Let's listen.
Dr. Ruth Karron, thank you so much for joining me on Public Health on Call to talk about RSV and new products to protect children from RSV infections. Let's start with the basics. What does RSV stand for?
Thank you, Josh, and it's really a pleasure to be here with you. RSV stands for respiratory syncytial virus. This is a virus that can infect people of all ages, but can cause severe disease in infants and young children. It is really the leading cause of hospitalization for children in the U.S. that are under a year of age. But it also causes, even for children who aren't hospitalized, absence from daycare, parents having to take time off from work. So it's really quite a problem. We've had some strange epidemics in the last couple of years because of the COVID pandemic and some of our patterns of behavior. But typically, RSV is a wintertime virus. It usually starts right around now in our area in Maryland, or at the end of October, early November, and then lasts through March. That's a pretty typical RSV season.
I remember seeing a lot of RSV in my clinical training, and particularly that it would be more severe among children who were born prematurely, particularly when they were young, as well as children with lung disease. Is that still the case?
Well, so it is true that if you're a premature baby or a child with heart disease or a child with neurologic problems that give you difficulty in swallowing and maybe therefore problems with your lungs, that you are at greater risk of severe disease. But when we look at the population of children who are hospitalized with RSV every year, somewhere between 75 and 85% of those children are little babies who are born full term, who have absolutely no risk factors, and were just unlucky enough to have been born a couple of months before the RSV season. I should just mention that even though RSV is the leading cause of hospitalization for children under a year of age in the US, it's most severe typically in infants under 6 months of age, 2 to 3 to 4 month olds. And there are a few reasons for this. And this is when it's typical non-pandemic times. But one reason may be because children's airways are tiny at that age, and RSV infection causes a lot of mucus production, and those little tiny airways just get clogged with all of the inflammation and all of the mucus.
Got it. So it's frequent, it can be severe, and it particularly affects the smallest babies, whether or not they were born prematurely, but particularly for babies born prematurely.
Yes, that's right. But we have had a product to protect premature babies for some time now. I believe the product just celebrated its 25th anniversary. But what's new this year is that we have products that are able to protect all young infants, all infants under 6 months of age.
Great. Well, let's talk about that. Tell me a little bit about what was available before.
So what was available and what still remains available, at least this year, is a product called palivizumab or Synagis. It's an antibody to RSV. It has to be given every month. and it's very expensive. It costs thousands and thousands of dollars every season. And so it's really only available in wealthy countries, and even within wealthy countries like the United States, there are real limitations on its use. So the American Academy of Pediatrics has really recommended that this product not even be used for all premature infants, but just the very, very premature infants for the first few months of age. Not because it's not useful in those older infants, but really both because of the expense and because of the difficulty of having to re-administer this drug every month during the RSV season.
So it's been helpful to some babies. I think there are some babies who may have needed it that didn't get it, perhaps because of some of the challenges getting it. And now we're in a new world this year. Why is that?
When I've talked to other groups, I've talked about 2023 as the year of RSV. And I said that back in January or February. And I think now that we're getting to the end of this year, it's really proven to be true. And that's because we now have two products that are highly effective at protecting babies under 6 months of age. One is an antibody. It's an antibody that's like Synagis, except two important differences, I would say. One is that it is long lasting. So you can give a single dose and it will protect a baby for the whole RSV season. And just to be clear about this, this is an antibody. It's not a vaccine. So once it's out of the baby's system, the baby doesn't have any immunity left to RSV, but they're protected during that really, really vulnerable time. The other important thing about this is it costs a lot less. It costs about $500. That's a lot of money, but it's a lot less than the original product, Synagis. And I should say, just so people know this, that this product, nirsevimab Beyfortus, it was made by AstraZeneca and is being marketed by Sanofi. There is another product called RSV Pre-F, which is a Brisvo. Some people might recognize that's being given to older people too, which we won't talk about today. But a Brisvo has also been licensed to be given to people who are pregnant during their third trimester so that they can boost their own antibodies. We all have some antibodies to RSV, but this helps boost those antibodies, and then those antibodies can be passed on to the baby. And both of these products are really highly effective at preventing RSV in young infants, on the order of 75 to 85% protection against severe RSV disease and hospitalization.
And the product to be used in pregnancy, is that a vaccine, or is it also just antibodies being delivered?
The product to be used in pregnancy is a vaccine, but what the babies get from their moms is just antibody. So these are two ways of giving antibody to a baby. One is giving the antibody directly to the baby, and the other is having the mom give antibodies to the baby by vaccinating the mother.
So how should these products be used?
So all healthy full-term babies should be protected with one or the other, either protected during the RSV season, right? So not necessarily need it year-round, but for protection during the RSV season. So either their mom should have gotten vaccinated between 32 and 36 weeks of pregnancy, or when they're born, if they're, less than 8 months old at the time of the start of the RSV season, they should get the Beyfortus antibody.
Are there any circumstances where it would be advisable to get both?
Not for most full-term healthy babies. An exception might be a preterm baby. So let's say, for example, a mom got vaccinated at 32 weeks of pregnancy, but then the baby was born prematurely at 33 weeks. That wouldn't be enough time for the antibodies to go from mom to baby. So in that circumstance, the baby would likely also get Beyfortus or should get Beyfortus to have complete protection. But generally speaking, most healthy full-term babies don't need protection from both products.
Are there any circumstances where a child might need treatment in the second year of life?
There are. So some of these babies with chronic conditions, either chronic lung disease or chronic heart disease, could need Beyfortus in the second year of life. That was true back with Synagis, with this original product. We recommended that for the second year of life. But the other population for whom this is a new kind of recommendation are American Indian and Alaska Native children are also recommended to get Beyfortus in the second year of life. And that's because hospitalization rates for these populations, even between age 1 and age 2 from RSV, are really extraordinarily high, much higher than the general population.
Now, this sounds like a plan to substantially reduce the burden of disease from RSV for children. But for it to work, kids actually have to be able to get the products. So how is that going?
So I will first start out by saying that I think people have tremendous enthusiasm, healthcare providers and policymakers, for the promise and the efficacy of these products. I think everybody agrees that these have, as you said, the potential to really substantially reduce the burden of RSV disease in children. But having said that, there are some difficulties right now in implementation. One of them has to do with, on the side of Beyfortus, the cost of the product and how insurers pay for the product. So my understanding, at least, is that from the time of a CDC recommendation, insurers have a year to guarantee that they will fund a product that the CDC recommends. Right now, these antibodies are expensive. They cost about $500 a dose. And most pediatric practices are small businesses. And, they can't all afford to buy many, many, many doses of this product without knowing that they will get compensated for their expenditures. I think a lot of people are working on this problem, including Sanofi and including the CDC, but it's a rough go. I think there are people who want to get this product for their babies who are not yet able to get it. And the season is here with us.
You're talking primarily about children who are privately insured. What about children who receive Medicaid? Medicaid is a public insurance program that covers an enormous number of kids in this country.
Right. So Beyfortus is covered under VFC, under Vaccines for Children. So we'll see how that is rolling out, how that's being provided. There's a big move to try to get more hospitals to make themselves VFC eligible, because ideally, if a baby's born during the RSV season, the easiest thing would be for them to get the shot before they ever leave the hospital. But right now, hospitals have not necessarily made themselves eligible.
What about the product for use during pregnancy? How is access to that product going?
So we'll see how it's going. There haven't been quite the same difficulties in terms of access and purchases. We haven't heard as much about that from healthcare providers. I think it will be interesting to look at the data after this season. And ideally, and CDC has said this, family practice docs and OBGYNs would talk to a pregnant person about choices of either getting an immunization during pregnancy or having the baby get a shot shortly after birth. So that's the ideal conversation that would go on so that people can make informed decisions. How that will work, I think we'll see as this season unfolds.
So we've got two new technologies that can really help prevent a very common and occasionally quite severe infection. But we don't quite know about whether people will be able to access them. We don't know what their impact in the world will actually be. So this might be something we check back with you on, Dr. Karron.
Yeah, and I will say that being an optimist, I have confidence that certainly it will be worked out in the long run. I think there's tremendous goodwill and political will to move these important products forward. I just think that it may not happen as quickly as we would all hope.
Thanks for joining me. Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.